Hello, Journey. Thank you for joining me today on the Public Health Wellness Team's webinar series. If you could please just go ahead and just introduce yourself and just describe maybe some of the projects and things that you're working on during this time.
Yeah, well, thank you so much for inviting me to join you, Nick.
Mm-hmm.
My name is Jerne Shapiro, and I'm a lecturer here in the College of Public Health and Health Professions, and I sit in the Department of Epidemiology.
Mm-hmm.
So I have my background is in working kind of boots on the ground field epidemiology.
Mm-hmm.
So I was in the Florida Epidemic Intelligence Service and then the county epidemiologist actually here for Alachua.
Wow.
So I have very applied experience in outbreak investigations.
Mm-hmm.
And over the past 6 weeks, I tried to I realize I have a unique skill set with
Right.
outbreak investigations, and I recognize
Mm-hmm.
that our local health department's resources were going to perhaps need assistance.
Hmm.
So I reached out to them and volunteered to be of assistance in any capacity that they
Great.
might need me.
Mm-hmm.
And it turns out that they were happy to have me reach out to them and
Mm-hmm.
deputized me to work and assist the Florida Department of Health. So
Wow.
in particular, I am working with the health department here in Alachua County. And
Gotcha.
what they're doing is uh, they are specifically handing me cases that are relevant to UF, so looking
Mm-hmm.
at student or staff that test positive for COVID.
Right.
And then, and sometimes if their team is overwhelmed, they will hand me community members to follow up with as well. And then I have a wonderful team of
Mm-hmm.
students that I've trained and have been working with, and I distribute these cases as they come in. The students will make the initial investigation.
Mm-hmm.
They do it's a lot of information that we gather
Sure.
from folks.
Right. Yeah. And this is the contact tracing, just to clarify, correct?
No, this is not
No, it's not.
contact tracing. This contact tracing, people want to like lump it all into one thing,
Oh,
right?
I'm
But
glad I
there's
asked
an
this
initial,
question.
yeah, so
Yeah.
there's an initial investigation that we do with folks. The contact tracing is part of it, but it is a part of it. So the first part is we got to get to know who this person is,
Hmm.
what they might have done in the last 14 days, where they might have become exposed.
Mm-hmm.
Did they attend certain parties? Were there large gatherings that they might have been to? Are there other places
Okay.
that where they could have gotten sick, right? So
Yeah.
in one aspect, we look retrospectively at a
Okay.
case to figure out where they've gotten sick from. And then we look forward in time. We're looking prospectively and we're trying to figure out who they might have gotten sick while
Oh,
they were
okay.
infectious.
Gotcha.
So,
Yeah, I
yeah.
haven't, I guess we don't think about that, just what I think recently in the news, we've, seen apps and things that we could be monitoring and try to be proactive that way. But nobody said the term like proactive, like we're trying to guess and predict essentially who could be the next set of positive patients.
Absolutely. And that's what
Yeah.
public health is all about, right? We are trying to work in the land of prevention.
Mm-hmm.
And it's been great. They've done some really great modeling from the Emerging Pathogens Institute, the biostatistics department there. And they looked at Boston as an example.
Mm-hmm.
And what the team showed was that if we are able to without any contact tracing. Let's start there. Without any contact tracing whatsoever, Boston's expected to have like 400 COVID cases a day, right?
Mm-hmm.
And so if we're implement contact tracing, even if it were just at 20%
Mm-hmm.
success rate of getting these contacts identified and then quarantining them for the next 14 days,
Right.
just 20% successful, we knock that caseload down to 100 cases a day.
Wow. From 400 to 100.
From 400 to
Wow.
100. And then if we're 40% successful, which we can do
Mm-hmm.
better than 20%, right? I mean,
Right.
I think that is absolutely possible. But if we're able to get it up to 40% success rate of identifying these contacts and quarantining them, it's down to like around the 50s.
Wow.
So contact tracing is an old, uh, old tool in the tool belt of
Mm-hmm.
breaking the cycle of transmission. And we
Yeah.
use it, I mean, it's all over the media right now, but we've been using this in public health, uh, you know, for, it feels like forever.
Mm-hmm. Right. It's only when a significant world event happens that we get to learn about it.
Absolutely. We're
Right.
like, yes, of course we do contact tracing. I mean, we do it for
Yeah.
everything. We do it from salmonella, giardia to Ebola. I mean,
Mm-hmm.
it's a very effective tool to
Sure.
help limit the spread.
Mm-hmm. So prior to our conversation now, we're recording on April 30th,
Yes.
2020. I've had the opportunity to chat with some of your graduate and PhD students that you oversee through this contact tracing and different pieces here. So let's
So
just,
proud of them.
yeah, you kind of beat me to it. I think, I've learned a lot through their interviews and they're very excited about the work. But I think as a supervisor, what are you most proud of all of their work that they've completed so far?
So I feel like I want to channel Mr. Rogers here,
Sure. Yeah.
where, I one of the things that his mother always told him that I heard was that um, when there is something bad that happens, she directed him to look for the helpers.
Mm.
Okay, so there's people that are impacted by the incident. There are people that flee
Mm-hmm.
from an incident, and then there are the people that are the helpers, and then those are the people that move towards
Mm-hmm.
the incident, have skills, and can make a difference. And I feel like my students that have said, I can help,
Mm-hmm.
and they recognize it, and they are self-empowered enough
Right.
to be able to hold the extra work, their course load, as well as their
Mm-hmm.
other responsibilities at the university, and say, I can do this.
Right.
They are the helpers. And
Right.
I'm incredibly proud of them
Mm-hmm.
because they were presented with a choice and they
Right.
chose to make a difference.
Yeah.
They're making a difference in people's lives. And it's really hard to measure
Mm-hmm.
what a difference they are able to make, because prevention is very challenging
Yes.
as a tool for measurement.
Mm-hmm.
But if we're able to get down the infection rate and prevent people from the numbers becoming so high that we don't have the medical capability to treat their needs, that we
Mm-hmm.
can slow and spread this out over time so that everyone who needs a hospital bed can get one,
Right.
then they have helped, and
Sure.
they should feel really good about it. And I think they should be
Mm-hmm.
proud of themselves for that.
Yeah, I couldn't agree more. It's a large commitment, time commitment that I've learned just through interviewing everybody. That on top of juggling a first, second, third year PhD course load and their own research, that it is
Mm-hmm.
really incredible that they're kind of the hidden warriors behind the lines that need to be celebrated like every day. And so it's what part of interviewing and speaking to people, just like, hey, let's recognize everybody's work because it's incredibly important.
Mm-hmm.
So I think I will by this is all said and done through working my way through the Department of Epidemiology. I think I would have spoken to at least 4 or 5 PhD students. Are there how many students or staff or workers do you kind of oversee as it relates to COVID-19 epidemiology?
So it's rolling on
Okay.
the number of cases that we have. So I
Mm-hmm.
have the ability to flex up and down. And one of the great things that I think was able to come out of this, and I got the inspiration from Dr. Hansen,
Mm-hmm.
was to create an independent study class from this.
Right.
So I have students that are enrolling
Mm-hmm.
in this class to get this
Right.
applied field experience. So we have flexibility of when
Sure.
they enroll and when they've met their time.
Right.
So, I have 4 people that I'm working with right now. It's been down to 2. I think I can scale it up to 10 or 20
Mm-hmm.
if we need to, because the economy is going to start opening up. This
Mm-hmm.
is going to be the lowest number of cases that we have for the next 1 or 2 weeks, and then we're going to see
Okay.
an increase in cases.
Right.
So I've started to make my phone calls and say, hey.
Right.
We've got the training that has been developed in the course site. We've got to get you through that. We're going to do mock interviews with them, get them the tools that they need to be successful. And then every single case has its own unique challenges. So working with them on each case as well.
So we will anticipate more cases, and we will, let's say if we use that 20% tracing rate, right? If we're successful in tracing 20% of the patients, is that, am I wording that correctly?
Identifying and quarantining. Not just identifying, they've got to be we can identify them. That doesn't mean that they're always happy to stay home for 14 days. And rightfully so. Like someone that I was speaking with, she's like, I'm the only person who's working. If I stop working, there's no money. They're not going to have, I'm not going to have a job back in 14 days. I'm not going to stay home.
Right. So yeah, with my background in behavior analysis, I just think of those as, those are competing contingencies. Like we have the cost benefit of, I may get sick, I could get others sick, but there's nobody to replace income and there's no other options. So as much as that is hard to hear, when you're talking to people, that's the reality of just the general support system that we have in place right now.
Yeah. And what's happening, right, is the deficits in our healthcare system and our workplace policies. This pandemic is shining a light on them and showing on a broader scale. If you practice public health in this regard, you already know it exists. But now it's like, hey, the rest of the world, look, when we have OPS employees and they don't have any sick leave, they are going to hide their illness. They're going to try to come to work because they have to pay their bills. Right. So, what I hope comes out of this pandemic is better policies to support the everybody in our communities, not just the privileged folks. Like I think of myself as a faculty member where I have sick leave and can work from home. Right. I have health insurance.
Right. Yeah.
I'm sulky.
Right. It's I was reviewing an article this morning on the phrase was the power of privilege in a pandemic. So just identifying that you have
it's endless
vulnerable populations, and if you're not a part of that, if you're not in special needs populations, the COVID-19 data. Again, do your due diligence on fact checking if you're watching, but we know the African American populations are more sensitive to COVID infection. Is that correct? Is that what they're
Well, I haven't seen that they're more sensitive to infection, but they have some of the underlying conditions occur more frequently in their population, such as cardiovascular disease, diabetes, that makes them at a higher risk for the severe complications.
Yes. I resort to the epidemiologist on the webinar to use the correct language.
Yeah, it's not like a certain population is genetically that we know of more susceptible at this time, and that might change. Right. We might find some genetic traits that people might cause people to have more these cytokine storms more frequently.
Sure. So whatever there'll be vulnerable populations. So whatever the data indicate those populations are, then we have we just have then other groups are then have privilege in a pandemic of if you're a white collar worker that can work from home and socially distant, all these supports are already in place that when a pandemic, when the onset occurs, then there's really not much in your life change. Whereas if you're a vulnerable population, the example in the article was special needs population often relies on public transportation to get from A to B. If that's shut down, then you have all these downstream effects and just makes you think about.
Our minority populations also tend to have the lower income earning jobs that are more service related, service sector related, and those jobs you have to show up for. So you can't work on your computer from home when you're working at a fast food restaurant or something like that. So they just don't even have the capability to be able to work from home.
So your background in training prior to the current pandemic, really just prepared you for this, just on a larger scale, correct? So it's like this is business as usual for you, but you just have more things, just generally speaking, to do. So you're running more tests, you're calling more people, you're filling out more information.
So wait, let me clarify something. So while my initial field experience has been in outbreak investigations, I have been an adjunct at UF for about 13 years and was hired on as full faculty in January of 2019. So I haven't been
Congratulations. That's recent. Yeah.
So I haven't been as field oriented. I've been more sitting in the lecturer position and teaching and sharing my knowledge with my students and trying to help them prepare to go out into the workforce and be successful and make a difference.
Yeah. Yeah. Thank you for that. So you have your field work experience. Now you're in the faculty, that position. So what have you, just with all of your background and knowledge, what do you see as kind of like the biggest barrier or resource that people need, just for overall, if we tie this back to wellness, like what is it that you see as, what is it, we just talked about vulnerable populations, the case study of a young lady who is the only breadwinner in the family. So, maybe there's not one answer for everybody, but have there been any general themes that you've kind of learned just through this process?
For general themes for myself or for others?
Whatever you're comfortable sharing. And maybe you can just speak for yourself or from what others, because if you have a lot of field experience, maybe you thought, we need more, I don't know, people want discounts on gym memberships. Maybe that's the thing. But now we're in this telehealth model. People just want a break from Zoom. Maybe you pick one tangible thing. I know sometimes these things are measured. I just want to maybe get a nugget of information just based on your expertise. Like, what do you see that people, need the most in these unforeseen times?
I think they need good information. I genuinely think that there needs to be a balance of information that's actionable.
Right.
That there has been perhaps over sensationalization in the media.
Sure.
And then the conflicting information coming out from political figures. Right. And I wish that we could just go, poof, politics, you play not a role. We're just going to give you solid, evidence-based information that's actionable so that people have a genuine understanding of their risks and can act and make decisions for themselves accordingly.
Yeah. I think you saw both articles that I read this morning, because it hit you hit just on that here, where it was the power of privilege in the pandemic article, and I can share this with everybody, but it's the author here. I'm just looking at it. He just said that there's just an overabundance of information. He just recognized there's an opportunity, regardless of political stance, just like you're saying, to come together and just share the one concise bit of information. We all want to help and link resources, but maybe that's counterproductive, because he even just, his anecdotal data where he got 26 emails from educational institutions from Australia and the United States. So it's, even if it's all good and repetitive, that's just 18 superfluous emails. And there's many, I think, opportunity within the health promotion umbrella to come together, decide on the information, and just send that one daily dose of good information. Could be,
Yeah, and I think one of the pieces that I'm finding, and this is personal, right? So I have every friend and family member that, I've come across in the last 20 years since I've been working in infectious disease epidemiology has made a phone call to me.
Sure. Oh, what do you do? Great.
Yeah. Oh yeah, I know somebody who does that.
My nose is running. The trees are blooming. What's happening?
Exactly. So, trying to lay out for them, they're all looking at these epidemic curves, and we've presented them as doing this beautiful trend downward now. And then what they're showing on, on a lot of levels is that it goes back down to zero. In the epidemic curves that the media is not media, but that is being distributed, there is no zero for this ever again. And I think that it's endemic. It's endemic throughout the entire world. It's going to be reintroduced to areas that have low, if they don't have high enough enough people there that are going to have antibodies and hopefully be protected in the future. We don't even know that. So I want people to have a realistic view that there is no zero. There is no safe time to be able to go back out again, that you can do things to help make yourself be safer. But there's no zero. And it is my opinion that right now we're actually at our lowest numbers that we're going to have, because as of yesterday, DeSantis has started to open up the economy again. So I think that we have about a 1 to 2 week lag period before we see an uptick in our numbers again.
And you say we as in the state of Florida, or us as a country?
So I say we because, and I'm glad you asked me to define that. We, to me, I'm looking at our region in North Central Florida.
Okay.
I think that it would be irresponsible for me to swath the entire state of Florida under one guideline of what we can expect to see. South Florida is experiencing a unique outbreak down there, and very different than what is occurring in the Panhandle, right? So we are changing with the tools that we have in our belts right now. Without an effective treatment or a vaccine, we can't change ultimately perhaps the total number of people that get infected.
Right.
All we can do is slow it down so that we don't overwhelm. Oh, I'm so sorry.
You're okay.
So that we don't overwhelm our medical resources. But ultimately, I think the numbers are 50 or 60% of the population is going to get infected. So it's 7 billion, over 7 billion people in the world. We're, half or more of them. So I feel like I want people to stop looking at what's this week and next week. I'm ready to look a year and two forward. Yeah.
And of course, you have that epidemiology background that
I know. I can see your
curves and prediction. No, I like to think in 2 to 6 months. I think that's a good shaping step. I'm just holding on to your idea of having good information, and we all know as researchers, we know what a bell curve looks like and the confidence intervals. And then that promotion article again touched on health literacy, right? Health literacy. It's easy to teach people a bell curve, but what you now are introducing, this is our baseline. That's a whole nother layer of good health literacy information. How do we communicate that as health promoters? It's just another cog in the machine here. Because really it's no longer a bell curve, because that's easy, like a bell, but shaped like this, right? Now for teaching people, what's the good information? It's going to be a jagged bell, and we're going to see multiple bells 2 years out.
Oh yeah.
Right.
Yeah. And it's going to be community specific. We're going to see an increase here in North Central Florida is not going to be reflective of what's happening in the Panhandle necessarily. So I think delineating those regions, and I just have to, as the educator in me, that an epidemic curve is not a bell curve.
Okay, sure. I'm the behavior science guy. So.
A bell curve is where you make it fit a certain form. of an increase and a decrease. And it's, symmetrical on each side of that bell curve. And epidemic curves, that's not what we see. I know that it looks like it, what they're presenting, and that would be like in a class, that would be the very first picture that I would show. Is kind of that uniform slope of up and down, but that's not really what happens.
Right. Yeah. So, as we anticipate the next year or two and things to come, what would you say would be? We have good information. What could you? I would imagine that predominantly, faculty, staff, and students at UF will be a large audience, for this video. What would be, one kind of closing idea or comment that you'd want to share with people as it relates to, taking care of yourself, thinking about wellness in the workplace, and kind of anything related there.
One of the things that I think about as we move forward is, and we reopen UF's doors, is I think that we've started to look at like somebody new as almost like they're an enemy now. Oh, you are somebody that can get me sick, perhaps. So I think that that's going to be a really interesting piece. And I would almost throw this back in the social behavioral science world.
Yeah.
We were a strong community and supported each other. And now we have almost where we look at somebody standing next to us at the grocery store and be like, you are within my 6-foot bubble.
Right. Yeah.
And how do we reintegrate those relationships and those friendships and the parts of us that support each other when we almost look at someone inherently as, I don't want to say enemy, but somebody who is an adversary that could somehow attack us on this viral microscopic level. And I think that's going to be a piece that we have to reckon with as we move forward.
Yeah, that's fair. I think from my own experience of going to the grocery store once every 10 to 14 days, you wear your mask, and it's like I'm somebody that, I like to follow the science and the government guidelines, and so you're in line at Trader Joe's and you're wearing your mask, following the rules, and you see somebody else that isn't following the rules. So naturally, you're just going to have this kind of barrier that's going to be hard to, bring in, that spontaneous social interaction. Because it's like, well, I'm following the rules and you're not following the rules. So I think we could have some interesting, it's going to be tricky.
So. It's going to be tricky.
Yeah. Well, Jerne, thank you so much.
We get to read it. Yeah.
Oh,
I was just going to say, we get to rewrite this.
Yeah.
So
right.
I think in some way that's kind of exciting. If we are thoughtful and cognizant of what we want the outcome to be like, we might be able to rewrite some of our social norms so that they're more positive, more inclusive, because we're being thoughtful on that level.
Yeah, I think so. Yeah, it's we could also think about, just a simple question of, oh, I saw you don't have a mask on. Do you not have one? I have an extra one. Here you go. That could create a new type of relationships and look at more towards, helping others and helping out our neighbors. It could create some new opportunities for us. So. Well, before the video kind of cut out, I was just going to say thanks again, Jerne, for chatting with me today, and appreciate your insights and appreciate your hard work.
Yeah, well, thank you so much for inviting me to come speak with you, Nick, and I wish you the best of luck in what you do and to be well.
Great. Thank you.